All right. Hello, everyone. My name is Ava Hutchings, and today I'm going to be talking about ableism and Audism, focusing in healthcare. All right. So I'm going to be focusing on this research question throughout my presentation, and it is how does ableism and Audism intersect with race, gender identity, sexual orientation, and age to shape unequal health outcomes for deaf patients in the United States? So, to kind of overview what I'll be talking about in this presentation, I'll start by briefly defining ableism and Audism. Then I'll move to the intersectionality framework based on Crenshaw's work, what we've really been focusing on throughout this semester. And after that, I'll break down the three forms of intersectionality: structural, political, and representational, and kind of show how each affect deaf patients and through examples. And then finally, I'll kind of explain why improving communication access and just representation in general in healthcare is very critical. All right, let me move this. All right, so first, what is intersectionality? So to understand these issues, I use Crenshaw's intersectionality framework from 1991. Intersectionality kind of explains how people's identities sort of overlap. For example, someone can be Black and deaf, and a woman could be LGBTQ plus. So these identities don't really exist separately. They interact together and can shape someone's experiences with discrimination. In healthcare, intersectionality can kind of create gaps and review why some deaf patients face more barriers and discrimination than others. This can be through the system design, the policies, as well as just stereotypes in general that all contribute to unequal treatment. So first, I'm going to define ableism and Audism in healthcare. So ableism is treating someone with a disability as something, as a weakness to them. Audism is the belief that hearing and speech are superior. So kind of ignoring even the systemic beliefs of deaf individuals and what they experience in general. And that can result in lack of interpreters and not great communication. So ableism and Audism in healthcare can impact kind of diagnosis and hearing out the symptoms of the patient, as well as just patients' safety in general and making them feel comfortable. Right, so first I'll be talking about the structural intersectionality. So structural intersectionality looks at how the system, so meaning the hospitals, the clinics, as well as their policies and regulations, can create disadvantages for people with multiple identities. So, for example, studies show that Black deaf mothers are often denied interpreters during prenatal care and childbirth. And also LGBTQ plus deaf patients frequently experience miscommunication because nurses and healthcare providers don't understand queer vocabulary in ASL. And older deaf adults also struggle because like telehealth and long-term care systems often aren't very accessible. And so these just come from how healthcare is built and not from the patients themselves, obviously, but kind of just how the system was built, sadly. So I have some evidence and some real life experiences and quotes that I wanted to share. All right. So these issues show up clearly in patients in their own words. So one older deaf adult said that every appointment feels like if I just understand what is happening. So meaning the provider or the interpreter isn't clearly understanding or is demeaning the older individual. Another study on transgender deaf patients found that providers often spoke language labels instead of respecting ASL identity markers. These real experiences can kind of show how the structural or how the structure of healthcare and how it excludes people when accessibility isn't really considered. So now I'm going to talk about political intersectionality. So political intersectionality looks at policies and laws that really should be protecting people, but don't really include with those overlapping identities. For example, hospitals are required by the ADA to provide interpreters, but it is a broken system, unfortunately. And a lot of those don't fully include or they don't follow through with that. And deaf people are often ignored in, especially deaf women are often ignored in women's rights issues and deaf rights issues. Similarly to that, deaf LGBTQ plus individuals are often faced with issues because interpreters are not really required to know LGBTQ plus terminology, especially in the healthcare world. And so it can be hard for them to communicate. Older deaf individuals are often left out of aging policies, which means that senior services may not offer that access. So some evidence in real life experiences. So as Crenshaw explains, political systems often protect some while marginalizing others. A clear example of this is how aging policies really include deaf seniors. Many elders end up in isolated care facilities because no one will communicate with them accurately through ASL. These policies kind of show that just these laws aren't really enough, and there's a lot of gaps, and healthcare needs more enforcement and training and just accountability in general to protect all patients, no matter what kind of, I'm like blanking now, not really dependent on what accessibility is required. All right. So now I'm going to be talking about representational intersectionality. Representational intersectionality focuses on how stereotypes, media images, and cultural messages can shape how people are treated. Black deaf individuals are often labeled as angry and aggressive just for advocating for themselves and just for asking for interpreters, and they can be seen as belligerent, and that's just based on stereotypes in general, which is completely wrong and just complete stereotyping, like I said. And then LGBTQ plus deaf patients may be misgendered because healthcare professionals don't really understand their identity or just kind of assume everyone's straight or cisgendered and ignoring all the subcategories. Older deaf individuals are sometimes treated like children or like they don't fully comprehend or understand. These people assume that when a deaf individual is taking a second to process or to figure out what someone who doesn't know ASL is saying, they assume that they can't communicate or make decisions. And all these stereotypes can really create barriers and stereotypes in healthcare. Some evidence and some quotes. In research studies, Black deaf mothers shared experiences of being negatively judged. One said they thought I was being rude just because I wanted an interpreter. That's quote unquote what she said. Another participant said they assumed I had memory problems. Oh, sorry. This was another participant who was a bit of an older gentleman. He said they assumed I had memory problems, but I really just couldn't understand their mouth talking. For LGBTQ deaf people, misgendering is common. One individual explained the interpreter didn't know LGBTQ plus signs, so they kept signing the wrong gender to me. I felt erased. So these stories can really show how harmful it can be and shapes the patient care and comfortability. So, in conclusion, or to conclude, ableism and Audism continue to shape healthcare experiences for deaf individuals when these forms of oppression overlap with racism, sexism, queerphobia, homophobia, ageism, all of them. The barriers become even more severe. Intersectionality can kind of help us understand why deaf patients' experiences are not just about their hearing status. It's more about their race and gender and all of that. To improve deaf healthcare and healthcare for these deaf communities, I think that we need better training, policy enforcement, and just more interpreter access for these healthcare workers about deaf culture and LGBTQ plus identities in general. And then this is my works cited. Thank you guys for watching. Bye.